Great, thanks. And thanks for your welcome. Just to get the conflict of interest out of the way, I have no huge investments in pharmaceutical companies. Too bad. And I have no ongoing research. I have a confession too. This session was advertised as knowledge translation when and how. I actually am taking this opportunity to ask you to consider another aspect of knowledge translation related to immunization. The learning objective is to better be able to translate research knowledge to frontline staff. Now, the dreaded definition, knowledge translation. I've taken this from CIHR. It says a dynamic, iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effective healthcare services and products, and to strengthen the healthcare system. Great. A simpler CIHR definition is knowledge translation is about raising knowledge users, awareness of research findings, and facilitating the use of those findings. Better. This is my definition, the one I like. Knowledge to action. It kind of reflects what I'm trying to say today. This is the model of the integrated knowledge translation for CIHR. It basically starts with talking to frontline people or your end users to shape the research question, and it ends with widespread dissemination and application of the knowledge. I've borrowed liberally from that model and tried to adapt it to the immunization process, knowledge to vaccine acceptance, starting with basics and clinical science research, to vaccine licensing, to NACI and CIC recommendations, to provincial policy decisions, i.e. funding is really what we're talking about here, provider education, client acceptance highlighted here, but I will not talk about that aspect very much. We've had some wonderful speakers prior to this session talking about the aspects of client acceptance and that complex and yet to be cracked field of knowledge. And we also are having some later speakers. I do want to encourage you to attend Dr. Cora. I will not try the last name, her session, the last one of the day. I always find her sessions to be passionate, informative, and it leaves me hopeful on the topic, which is always nice. Instead, I want to emphasize two other aspects of the knowledge transfer within the immunization process, and that is specifically provider education and provider acceptance and communication skills. I've changed the model yet again to fit my analogy more readily. So now I'm trying to represent the transfer or translation of knowledge in the immunization process as a chain of interlocking links, each of which have to be very strong in order for the chain to function as a whole. So in this model, it's exactly the same as the previous ones, except I've added disease surveillance at the beginning, leading to basic research and basic and clinical research, vaccine development, on through the NACI and CIC statements, through to emphasis on provider education, provider acceptance, and provider communication, to client acceptance, lots of challenges not addressed here, to safety monitoring, and back to disease surveillance so we can understand the effectiveness of our programs. So, provocative question, is the immunization provider a weak link in the chain? They are linking, I heard the word never. I think sometimes they are. That's what my thesis is today. They are the link between the information regarding recommended vaccines and client or patient acceptance. In a link that's working or solid, they have good solid knowledge, they accept the benefits of vaccines, and they feel confident in communicating both the benefits and the risks and the relative strength of each. In a weakened link, there is the factors of misfearing, mistrusting, and misunderstanding. Just to clarify that or unpack that a bit, just a bit, our immunizers are just human. We all know people, or you probably know people, that are very, very nervous about flying, but will happily jump into a car and take a trip. If you didn't know one, you know one now. It's crazy. It doesn't make any sense whatsoever. Air travel is way, way safer than car travel. We know that. And yet, people continue to be nervous about flying. In the immunization realm, this distorted risk perception related to risk analysis, or what we feel about risks compared to what the information shows about the risk, is kind of sideswiped in a way such that the side effects are weighted much more heavily. The vaccine effectiveness is minimized, and the disease effects are also minimized, or perhaps it's the strength of one's own immune system, or the effect of just getting a good night's rest has on your immune system. This seems to be a human tendency. It happens in our clients, and it happens in our providers. There's also the aspect of a lack of confidence in the truthiness of the information, Anyways, this is the concept of there is a lot of profit to be made by the pharmaceutical medical community, and this vaccine drive is really to make money. In our staff, there's also the concept of mistrust of the organizational targets. Do they really care about patient safety or my well-being, or do they just want me to take less time off in the winter? And we just have to realize that that's part of the dynamic. Again, people with bigger brains in these 2 days have talked about this previously, and we'll talk about it again this afternoon. This is a reflection of that resistance to immunization. This is influenza immunization. This is the Alberta rates for 2013-2014, hot off the press. I must say, I was actually gratified by this information because we made it over 50%. And then I feel a bit chagrined because we made it just over 50%. And I'm really pleased because it's been sitting at 40%, 45% for years. 50% is outrageously low, and yet here we are. So we've got a lot of work to do with our own staff members. The possible solutions to the misfearing and mistrusting are to engage providers and understand concerns, to address the concerns as appropriate and as possible, and to translate knowledge, the learnings that are coming increasingly from research related to risk perception and risk communication, and effective communication using things like social media. Again, people with bigger brains, more knowledge, have talked about this and will later this afternoon. I want to look at the other aspect, the misunderstanding. And what this is a lack of knowledge on the part of our immunizers, or the lack of confidence in their knowledge. Now, one of the big reasons my colleagues tell me about this possible misunderstanding is as a result of all our, albeit slow, uptake of new vaccines. We have had the riches of many new vaccines recently in the past 10 years. We've got human papillomavirus, we have flu mist, which is a new delivery, a new eligibility. We've got rotavirus quickly on the horizon. We've had many, many program changes. We have adult Tdap or DTaP. We've, here in Alberta, had the expanded MMR program in 2013. We've had varicella second dose. We're looking at HPV expansion to boys. We've had many new formulations and new manufacturers of vaccines, resulting in many, many small changes to our programs, whether it be eligibility, vaccine components, timing, etc. it's a lot of new information, a lot of changing information, particularly if you're an immunizer that does this as part, and only a small part, of your job, either part-time within public health or as a busy physician in an office. It is difficult to keep up. The possible solutions to this is a translation of recommendations for immunization providers in a timely, I'm missing timely, but I'll put in timely just to be more demanding, easily accessible, using simplified messages with, sure, the addition of references and background material sources for those who are interested or have questions, and using very clear language. We have some examples of that, and BC has been generous enough to provide, oh my goodness, 0 minutes. I guess I'll stop here. No, I'll finish. To provide the copies for each of the members here, or participants here, of the 2013 Immunize BC. And this provides both clinical and client knowledge divisions on topics in a very attractive, very simple, very accessible format, and I ask you all to really look at that carefully. Now, I'm the kind of person who says, thank you very much, what can you do for me today? And what I'm going to do is challenge BC or anybody else in any other jurisdiction at this conference to say, can we have the same type of information related to each vaccine? Because the general information is great and very helpful, but our users need it about each vaccine. There are other interested parties, many other interested parties, and I came upon this publication just a couple weeks ago, and it's from the American Academy of Pediatricians, or Pediatrics, and it says, pediatricians can lay out evidence to allay fears over HPV vaccine, and it's simply a page and a half of very clear language, 16 points to answer questions about vaccine, 8 about related to effectiveness, and 8 about safety. And all of us have to start providing clear, more simple messages to our vaccine providers so that they can provide knowledgeable, our vaccine providers can be knowledgeable, they can value vaccines, and because of the knowledge, they can confidently communicate to the clients and be functioning as a really strong link in the immunization process change. Thank you very much.